This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from Langenbeck's Archives of Surgery, published in 2026. It's a single-center retrospective study titled Effects of Cranioplasty with Customized 3D Titanium Mesh Plates on Postoperative Complications and Neurological Outcomes Following Traumatic Brain Injury or Stroke.
This is a topic that hits home for all of us in the OR. We perform decompressive craniectomies, or DCs, regularly to manage intractable intracranial hypertension. But the second act, the cranioplasty, or CP, is where the nuances of long-term recovery really live. There's always been this persistent controversy surrounding the timing and the risk factors for complications.
Exactly, Dr. Aris. This study specifically looked at 180 patients who underwent CP using 3D titanium mesh between July 2019 and December 2022. They were tracking these patients for 12 months post-op to see what went right and what went wrong.
And for our listeners, it's worth noting the inclusion criteria. They focused on patients who had their initial DC due to either traumatic brain injury, or TBI, or hemorrhagic stroke, which included both subarachnoid hemorrhage and intracerebral hemorrhage. They excluded tumors and ischemic strokes to keep the cohort somewhat uniform. Ilara, let's talk about the demographics first. Who were these patients?
It was a predominantly male cohort, 118 patients, or about 66%. Trauma was the leading cause for the initial DC, accounting for 123 cases, which is about 68%. The rest were stroke-related.
When we talk about complications in cranioplasty, people often think of infection first, but this study shows a much broader spectrum. What was the overall complication rate?
It was actually quite high, an overall incidence of 45%. Now, that sounds daunting, but it covers everything within a 12-month follow-up period. The secondary endpoint was the Glasgow Outcome Scale, or GOS, at 12 months, where they found poor neurological outcomes in 30% of the cases.
45% is a significant number. Let's dive deeper into the specific predictors they identified. One that stood out to me was the relationship between the dural surface and the mesh.
Right. The study found that intraoperative dural depression during the cranioplasty was significantly correlated with an increased likelihood of postoperative epidural effusion.
That makes perfect sense anatomically. If there's a significant dead space between the 3D titanium mesh and the depressed dura, you're creating a vacuum or a potential space for fluid to collect. For the residents listening, this emphasizes the importance of dural stay sutures, or perhaps adjusting your plate contouring if the sinking is too pronounced.
Another major point of contention in our field is when to perform the repair. There's always the debate. Do we wait for the brain to settle, or do we go in early to restore physiology?
And what did the paper find regarding the 3-month rule?
The data was quite clear here. A time interval exceeding 3 months between the initial DC and the cranioplasty was associated with a heightened risk of hydrocephalus. Conversely, performing the CP within that first 3-month window appeared to be safe and did not increase the incidence of other postoperative complications.
That's a crucial takeaway. The paper mentions how the prolonged absence of the skull flap leaves the brain vulnerable to atmospheric pressure variations and shifts in cerebrospinal fluid hydrodynamics. We often talk about sinking flap syndrome, where the atmospheric pressure literally pushes the brain tissue in, causing motor, cognitive, and language deficits. By closing the defect earlier, we are essentially normalizing that pressure and cerebral perfusion sooner.
Interestingly, while the timing affected the risk of hydrocephalus, it didn't seem to correlate with the final GOS score. The study found that surgical timing wasn't a predictor for poor neurological recovery. Instead, that was more closely tied to the patient's status before the cranioplasty.
Right, the starting point matters. They identified the pre-DC GCS score as a major contributing factor for the 12-month GOS. If you start with a lower Glasgow Coma Scale score at the time of the injury, the cranioplasty can only do so much.
They also noted a difference between TBI and stroke patients. Specifically, stroke patients undergoing CP tended to exhibit poorer neurological recovery compared to those with TBI.
That aligns with what we see clinically. Hemorrhagic strokes often involve deep-seated damage or global vascular insults that differ from the focal or diffuse axonal patterns in trauma. Now, Ilara, what about the surgical technique itself? Did the study mention bilateral procedures?
Yes, and this is a big one for postoperative wound care. Patients who underwent bilateral cranioplasty demonstrated an elevated risk of wound dehiscence and infection.
Bilateral plates mean more hardware, more tension on the scalp, and often these are patients who have had multiple prior surgeries on both sides of the head. The blood supply to the scalp can be compromised. If you're a resident managing these patients post-op, you need to be hyper-vigilant about those incisions.
To summarize the risk factors the authors found, if you have dural depression, watch for effusion. If you wait more than 3 months, watch for hydrocephalus. If it's a bilateral case, watch the wound like a hawk. And if the patient is a stroke survivor, manage expectations regarding their GOS.
It's a lot to juggle, but let's look at the customized 3D titanium mesh aspect. The study specifically used this material. Did they touch on the benefits of 3D customization?
The paper notes that CP is done not just for aesthetics, but to shield the brain from secondary damage. The 3D titanium mesh allows for a restoration of the normal cranial contour, which is vital for the physiological recovery of CSF flow. They suggest that the customized nature helps in fitting the defect more accurately than traditional hand-bent mesh.
However, even with the best 3D fit, we still see that 45% complication rate. It reminds us that cranioplasty is far from a simple procedure. It's a major physiological reconstruction.
For our practicing neurosurgeons, the study's conclusion is quite proactive. They explicitly state that early 3D titanium mesh CP, performed within 3 months, appears to be a safe procedure. It doesn't increase your risk of complications, and it might actually save the patient from the hydrocephalus that comes with a delayed repair.
That's an important shift. In the past, some centers waited 6 months or more to ensure all swelling was gone and any potential infection was cleared. This study pushes us towards that 90-day window.
Before we wrap up, I want to touch on this sinking flap syndrome again. The authors mentioned it can lead to severe manifestations that are life-threatening. By restoring the skull, we aren't just fixing a hole, we're restoring the intracranial pressure environment.
Absolutely. And we're also helping with the psychological and social aspects. The paper mentions that extensive skull defects lead to psychological disturbances and difficulties in social interaction. We shouldn't undervalue the impact of restoring a patient's appearance on their overall recovery.
So the key takeaway for the warts tomorrow.
If the patient is stable and the scalp is healthy, don't wait. Aim for that under 3-month mark. If you see dural depression in the OR, consider your strategies to minimize epidural space. And for the stroke patients, be realistic with the families. The recovery is often tougher than with trauma.
This was a great deep dive into the 2026 Langenbeck study. It really clarifies some of those gray areas in cranioplasty management.
It certainly does. Thank you, Dr. Alara, and thank you to our listeners. We hope this helps you in your next clinical rotation or your next case in the OR.
See you next time on the Neurosurgery Hub podcast.
Stay sharp.